Hi, everybody. Welcome to the Queen's Global Oncology Masterclass and Critical Appraisal Live edition. My name is Scott Berry. I'm a medical oncologist and head of the Department of Oncology in Kingston, Ontario, Queen's University. And it's my pleasure to be here today and welcome people from around the globe for this live session. Our masterclass in critical appraisal is based on online modules, and you can see here, if you have not done this, I would urge you to have a look at it. It's available on our website. And our first masterclass is focused on critical appraisal and the randomized clinical trial. You can see that there's a number of faculty from Queen's and other institutions around the world who have contributed. And this one is focused on Dr. Priya Ranganathan's session on the randomized clinical trial. We are working on subsequent additions to this masterclass, and we'll be having masterclasses in the new year on biostatistics and initiating a research project. So thanks to all of the contributors to this online program, Dr. Thrawanka Ridgeratney, who's on the line today, Dr. Nazak Ahmad, Priya Ranganathan, Vishal Giawali, Chris Booth, and today's speaker, Dr. Ian Tannock. Today's live event is with Dr. Ian Tannock. It's my pleasure to introduce Ian. I've known Ian since I was a medical oncology trainee. Since then, I've had the pleasure of working with him on many projects, and it's a real pleasure to continue to work with him on projects like this. And we were able to visit South Asia together and have a very interesting professional time in September. Dr. Tannock needs no introduction, but I'll just lead on by saying that Dr. Tannock is an emeritus professor at the University of Toronto, Princess Margaret Cancer Centre. He is a brilliant scientist and has contributed a lot to the understanding of the basic science of oncology, and has in fact written a textbook on that. He is an eminent clinical trialist and has published many of the practice-changing trials in oncology in the past decades. And as an important complement to that work, which have really been profound impact on improving the lives of people with cancer all over the world, Dr. Tannock's been committed to making sure that as we read the literature related to cancer, that we do it in a rigorous way, we do it in a thoughtful way, we are skeptical, and make sure that as we read the literature, we understand it and are able to integrate it into our practice to ensure that we have high value practices. So we're very fortunate to have Dr. Tannock here today. Just in terms of how the event will fold out, Dr. Tannock is going to do a review of a randomized clinical trial, which has been distributed previously, and go through highlighting some of the principles that have been elucidated in the online modules. And then we're going to have small breakout sessions where we're going to be able to answer individual questions and help people work through issues that were raised either in the online sessions or in Dr. Tannock's discussion, and that will give some time for some small group interaction. I'd like to thank, we have a committed group of facilitators who'll be working in those rooms today, and I'd like to thank them all. They're listed here. So without further ado, thank you, Ian, for leading today's session, and I'll hand over to you.
Okay, thank you, Scott. So I will now try to share my screen. That's not, let me just make sure that I've got, I thought I had this up. There's my slides. I'm not technically brilliant, as many of you can see. Here we go. And I think we're just about there. Let me just...
Yeah, there we go.
Looks great.
You can see your slides perfectly, yeah.
Let me just try to change the view, because all your pictures are down the side here. And let's see, yeah, that's better. Okay, so what I've chosen to discuss today is actually two papers. One that's the same trial, and one is an update of the other, which has, these papers have purported to show that adjuvant pembrolizumab immunotherapy should be used for people with high-risk kidney cancer after their tumor has been used. So that is adjuvant treatment. And so the question I'm posing to people who are listening in or watching is whether patients with high-risk kidney cancer should indeed receive adjuvant immunotherapy based on these studies, because obviously the plus side is that hopefully it might improve their outcome. The negative side is that we're dealing with a very expensive drug with some toxicity, and if the benefits are not proven, then that would not be a good thing to do. So in terms of conflicts of interest, I never speak for companies. I don't accept personal payments from them. And I know it's difficult, but I would regard this as an important thing for young people to do, because as soon as you start accepting payments from companies, you are beholden to them. And I published some editorials in the Annals of Oncology. One of them was called Purchasing Silence, and relatively small payments to doctors as a way of silencing any type of criticism of trials like this and of the obscene costs of some of the drugs. And so remaining independent of companies, at least not accepting personal remuneration, is important. It doesn't mean you can't work with them to help do good clinical trials. But my policy is always, if there is any money involved, that go to a research fund and not to my pocket. And the other thing is that this disclosure business is really a little bit of a joke. I mean, if you now look at the disclosure that is at ASCO or ESMO, sometimes the disclosures take as much space as the abstract. And secondly, when people show the slide, I actually measured this in an ESMO meeting from not the last one, but the one before. And the median time that it's on is just a few seconds. And so it really is paying lip service rather than being real. Anyway, so I don't have any conflicts of interest. In fact, I'm quite proud that many of the companies would love for me not to be giving sessions like this. So let's focus on this study. The primary report was in the New England Journal of Medicine, as are many of the quotes practice-changing studies in last year, 2021. You can read the title. And then the update was in Lancet Oncology this year, actually published very recently. And the primary endpoint, and we'll go into some of the problems with this as we go along, the primary endpoint was disease-free survival, assessed by the investigators in the intent to treat population. That means that you randomize patients, and no matter whether they receive the treatment or not, obviously most of them do, but sometimes for one reason or another, but it doesn't, you evaluate the policy, and that's good. And disease-free survival means that there is no event, no recurrence of the tumor or death of the patients. And this was the difference that's shown in the most recent paper. So disease-free survival percentage with time after randomization going out to about 4 years. There's clear separation of the curves. There is a hazard ratio, which I'll explain to you a little bit later as we go along. And there were more events, more recurrences or deaths in the placebo arm compared with the pembrolizumab arm. So I think if you're busy and you don't have much time to think about this, you would say, wow, looks good. And in fact, the advisory committees to the FDA, the Food and Drug Administration in the US, and the European Medicines Association, which actually register drugs and how they can be used, both of them followed the publication of these papers and of course the application from the company that makes pembrolizumab and approved pembrolizumab for adjuvant treatment of renal cell carcinoma. And so it's approved. It will be in guidelines to suggest that it be used. But I think it's important to look beyond just what's in the abstract and really ask the question, is the evidence really strong in terms of showing the benefits, the clinical benefits of this treatment? So, important considerations when you review a report of a clinical trial can be separated into internal properties of the trial. Basically, was the trial well designed and conducted? And external events, how consistent is the results of this trial with other evidence that's out there in the literature? So when you think about the internal validity, you should ask yourself, well, was the question they asked important? Were the entry and exclusion criteria for patients appropriate? Was intention to treat analysis used? And as we've seen, it was. Was the primary endpoint appropriate? Is the toxicity evaluated well? And what happened to the patients after they went off the trial? Were there other things happening that could have affected the long-term outcome? And then, as I said, external validity is whether it's consistent with other studies that have been reported. So in terms of assessing it, Bishal Gaiwali, who is certainly a member of our Masterclass team, but I think is not available today, was the lead author with the ESMO clinical value investigators in writing this very nice review about biases in study design, implementation, analysis that can distort the appraisal of clinical benefit. And he had a diagram that I've actually adapted because has too many boxes and writing too small to be shown in a slide. And this is an adaptation to how you might look at a randomized clinical trial that is seeking to show benefit, so a superiority trial like the one we're talking about here. And he points out a number of biases that I'll explain to you as we go along: informative censoring, crossover issues, what treatment did people have later, quality of life analysis, less important in an adjuvant trial than a palliative trial, unplanned analysis, substandard controls, etc. So we'll use this as a marker, and I think this slide can be quite useful for you, and Bishal and colleagues' paper can be useful for you when you next review a large randomized trial published in the literature. So these are quotes from the recent paper. They have a section called Research in Context. So what they say is that there have been 5 studies of VEGF-targeted therapy. These are tyrosine kinase inhibitors like sunitinib, sorafenib, pazopanib, etc. And although one of them was registered, in fact, it's very rarely used. And there is no consistency to show any real benefit in the adjuvant setting. So VEGF-targeted therapy as adjuvant therapy should not be used. There are no reports at the time that this trial was designed, and even the first publication, there were no results from phase 3 clinical studies investigating adjuvant immunotherapy for patients with renal cancer after surgery. And so they concluded that there was an unmet clinical need, and I have no problems with that. And then they stated that this trial was the first randomized phase 3 study to report results as an adjuvant therapy for patients with renal cell carcinoma. But as we will see as we go along, it may have been the first, but it was only just the first. Now, what about their entry and exclusion criteria? Adults over 18 with a clear cell renal carcinoma with an increased risk of recurrence. That seems absolutely fine. They had to have a reasonable performance status and to have had surgery within 12 weeks or so before randomization. Perfectly fine. There are some patients who present with metastatic disease where you can resect the metastases, and if they had complete removal of those metastases, then the patients were eligible. And again, I think that's fine. Randomization was stratified. That means that you have sort of equal numbers in the groups with M0 and M1 disease, and then you further stratified by the performance status and by the geographical region. And that way you get, in a large trial, roughly equal numbers of patients with different characteristics. And again, those check marks being that I think that's a good design feature of the trial. The paper has a table showing baseline demographic and clinical characteristics, and it shows that indeed these characteristics were well balanced between the arms. So for the initial randomization, I don't think there's any problems in stating that the two groups that were compared, those that did and didn't have the therapy, were actually well balanced. Then the intervention. So pembrolizumab at what is an approved dose, or the placebo, were administered every 3 weeks. So they had a placebo control. This was done double blind. The patients and the doctors didn't know which they were getting, so that avoids bias. And they were treated every 3 weeks up to 17 cycles, which is a year of treatment, until they then either stopped, or that was stopped early if there was progression or recurrence or some very severe toxicity. All the participants and investigators were masked, so there's no way that they could know that one group was being treated preferentially. They looked at PD-L1 expression, but that's not going to be a core assessment here. And the imaging assessments were done every 12 weeks in the first 2 years, every 16 weeks thereafter, and then every 24 weeks. So they looked at a standard schedule to try to determine whether there was development of metastatic disease. And that's, again, absolutely fine. And toxicity was graded according to the NCI common terminology criteria for adverse events. Again, it was fine. The endpoints, the primary endpoint was disease-free survival. And that, as I've stated, was the time from randomization to the first documented local or distant recurrence of renal carcinoma, any secondary malignancy, which was rare, or death from any cause. And again, that was rare that patients died from disease from any cause other than the cancer itself. Now, a key secondary endpoint was overall survival, that defined from the time of randomization to death from any cause. And that's obviously ultimately what you're trying to do with adjuvant therapy. You're trying to improve survival. And efficacy, again, was assessed in the intention to treat population. So all patients were included regardless of the treatment actually received. Other endpoints included toxicity, tolerability, looking at the results with the PD-L1 score. So the PD-L1 score is asking about the expression of PD-L1 in the tumor cells and the lymphocytes, and in some, but not all types of disease, the immunotherapy is more effective if the PD-L1 score is high. And they had an external data monitoring committee. So these are a group of people, usually consisting of at least 3 or 4 people. Typically will include a couple of investigators who are familiar with this type of trial, but not involved with it, a statistician, and often a patient representative. And they are looking as the results come out of the trial. So they are given the results, whereas the people running the trial are not, to make sure that there's no unexpected events and toxicity that might lead them to say, well, this is no longer a good trial, your patients aren't doing well. So that is standard for very large trials like this one. And it's a good thing because it ensures an independent committee that looks after patient welfare. Now, what about the statistical plan? So when you're planning a large trial like this, how do you plan it? So they plan to enroll almost 1,000 patients with equal randomization to the groups who got and did not get adjuvant immunotherapy. And the way they calculated that sample size was they wanted to ensure a 95% power to detect a superiority of one group versus the other with an alpha, and I'll explain that in a minute, so that they would be able to detect a difference if it was there, and would not falsely show a difference if it wasn't there. And I'll come to that in the next slide. And I'll also explain that concept of a hazard ratio, meaning essentially that the rate at which people were recurring was 1/3 less in the active group, the pembrolizumab group, than in the controls. They had a time of first analysis. They have a time of final analysis when there's been a certain number of deaths, because the power of the study depends on the number of events, not the number of patients going in. And the statistics were adjusted for multiple comparisons. The more tests you do, the more you are likely to find that one is positive simply by chance alone. So you need to correct for that. So let's go into a little bit more the statistical basis for planning the sample size for trial. Now, I'm not a statistician, but you do need to have some very simple idea of how you do that. So first of all, in designing a trial, you need to ask, well, what's the difference in outcome that is important enough that you wish to detect or rule it out? And you can call that difference delta. It can be a difference in survival, or it can be expressed as a hazard ratio, a ratio of events. And then the probability of committing what is called the type 1 area is where you report a difference at least as big as this difference that you want to detect when there is none, and that's called alpha. And typically alpha is set at 0.05, meaning that if you find a difference at least as big as the one you wanted to, that you accept that being 95% certain that is valid. And then there's the probability of committing a type 2 error, that's reporting no difference between the randomized groups when one actually exists, and that's called beta. Beta can be set at 0.05, 0.1, or 0.2, and the inverse of beta is the power of the study. The probability of detecting a difference greater or equal to delta if it really exists. So typically you want that to be at least 90% a probability of detecting the difference. And in this trial, it was set at 95%. So all of that is absolutely fine. Now, what is a hazard ratio? So when you do a randomized clinical trial, it's not like an animal experiment where all the animals could be treated at the same time, and then you follow them to see what happens. In a randomized controlled trial, patients are entered at different times, and hence their follow-up is variable. So you may have some patients that were entered 3 or 4 years ago, they got 3 or 4 years of follow-up. You could have some patients that were entered a year ago, and they've only got 1 year of follow-up. And so how do you analyze a trial where you've got patients come in at different times? And the events, of course, in this case, disease recurrence or death, will occur at different times. So the way that you generate that is that the survival curves are generated by dividing follow-up into discrete time intervals. So the probability of dying in each interval is estimated by dividing the number of people who died during that interval by the number of people who are alive at its beginning. And of course, as you go further out with fewer patients having lived that long, then that number goes down. And the actuarial assessment of the probability of surviving for a given time is then calculated by this cumulative multiplication of the probabilities of surviving each interval until that time. And that leads to the survival curve, or in this case, disease-free survival curve. The hazard ratio is the relative probability of dying in the experimental and control groups in any disease in any discrete interval. So if your study drug works, then you expect fewer people to die, or if you're looking at disease-free survival, to relapse in any given interval compared with those who don't get the drug. And that is the hazard ratio. And a big assumption is that it's constant over the follow-up time. And that isn't always satisfied. It isn't even always looked for. And that assumption is called the assumption of proportional hazards. The hazard ratio is not the overall difference in the number of people who have died in, say, the pembrolizumab group with as a ratio of the control group. That is not the hazard ratio. It is the hazard ratio applies to small discrete intervals. And for reasons that are a little bit too complex for me to go into, that isn't the same as the overall difference or ratio of dying. Now, in any randomized trial, it's important to have a consort diagram. This was a diagram that tells you how you get the patients in the trial, how many you excluded and why you excluded them, how many were enrolled, and how they were assigned to the different groups by randomization. It's important because here you have, say, we had 1,406 patients in this study, and 412 were excluded. Why were they excluded? So 156 of them still had cancer present, so they weren't fitting the eligibility criteria. Another 125 didn't meet other eligibility criteria. 66 didn't meet the criteria for having high-risk disease, and 65 withdrew consent during screening. So actually, that's pretty good. You've got to rule out the patients who don't fit the entry criteria, and you haven't lost a lot of patients who withdrew consent during screening. There are some randomized trials where you may look at an extremely large number of patients, say 2,000 or 3,000, to get, say, 1,000 that go into the study. And when that happens, that raises concerns that either the physicians are saying, well, this patient isn't really that good for the trial, expressing their biases, or whether the patients themselves are concerned about the treatment. So here, I think the entry is pretty good among the patients who were assessed. And so you've got 994 enrolled, you've got all of them assigned, and you have fairly equal assignment by the randomization. So that's worked well. And if you go on down the diagram, how many actually got the treatment? Well, if you look at the pembrolizumab arm, 8 didn't receive the assigned treatment. That's not too bad at all. There's always some reason. Patients withdrew. 3 were found to not meet the inclusion criteria after they'd been randomized. That should have happened before. So you still have quite a reasonable balance between those who received the assigned treatment, 488 and 496. And then you have in the next box why people discontinued treatment. And one thing that is obvious is that there are more adverse events in the pembrolizumab arm. Well, that's not surprising. We know that this drug does cause side effects, not necessarily for most patients, very serious side effects, but nonetheless some serious inflammatory side effects. And you can see that there is clearly a difference in the number of patients who relapse. That's that blue box. But you also see that there are more withdrawals in the pembrolizumab arm than in the placebo arm. And we'll come to that later. Now the primary endpoint. Now there are only 2 things that you can do to help your patients with cancer. Either the patients, you can help them to live longer, or you can allow the patients to live better. So the ultimate endpoints of a phase 3 trial for for either overall survival or quality of survival. And if you use another endpoint like disease-free survival, it's really important that ultimately they be a predictor of one or the other of those. And if we're talking about adjuvant therapy, most patients are willing to put up with some fairly large decrease in their quality of life to improve long-term survival, whereas quality of life becomes much more important if you're looking at a trial of patients who are all destined to die of their tumor, those with advanced disease. So the primary endpoint was disease-free survival, as we've said, and the secondary endpoint was overall survival. And we don't have, the data is still immature for that. So here was disease-free survival. I showed you this curve earlier, and this was the curve that led to the registration of the drugs. And I showed it to you before. Without those numbers along the bottom, that one tends to forget about. You look at the p-value, the hazard ratio, 0.63, says there's a 37% decrease in any discrete time interval that the patients will relapse if they get pembrolizumab rather than placebo. So that all looks pretty good, and the p-value is strong. But now let's look at these numbers down the bottom. So if you look at the early times, one of the things that you can see is that the numbers at risk, and they go down because either people have relapsed or they haven't been followed very long. And the number in brackets is the numbers were censored. So what does censoring mean? It means that these patients dropped out before the time that they reached their primary endpoint. So at that 20-month period, 43 patients in the pembrolizumab arm and 23 in the placebo arm have dropped out before the time that they actually, their disease either recurred or they died. And as you go out, you can see the numbers at risk go down quite dramatically. And one of the lessons of looking at these curves is that the tails of the curves are not very reliable because they're not depending on many patients. But let's come back to this difference in censoring. So effectively here, you've lost 43 patients in one arm and 23 patients in the other. And where there's a difference in censoring, that's called informative censoring. And it's a neglected cause of bias in oncology trials. And here are 3 papers, one of our own and 2 by other people, looking at the problem of informative censoring. And this is something that is rarely recognized by oncologists. It's rarely recognized by advisory committees to the FDA and the EMA and others. And in fact, FDA put on a recent meeting about this, a virtual meeting that I talked in. So what it is, a difference between the arms of participants being censored, being lost to the trial before documentation of, in this case, tumor relapse or progression. And note that's not likely to occur if the endpoint is overall survival. You have patients dropping out before you document whether they relapse or not, but you can pretty much get all the information as to whether the patients are alive or dead. And this negates or at least causes bias in the principle of randomization. If there is more censoring in the experimental arm, then the curves are not comparing all of the patients at the beginning. Their comparison is between those who stay on treatment, and that's those usually who are doing well, with a less selected control group where people have dropped out. So I've worked with a colleague, Tomer Maassen, who is in Israel, and he's published on this. And so one of the things you can do is look at the curves that were published in this paper. And here's the curves that were published. I've taken out the other things to make it simple. And then correct those curves where when a patient is censored, you actually assume that this is an event. So this is, if you like, time to treatment failure, time to either having a relapse or dying or withdrawing from the study. And if you do that, those are the curves that you get. There is still a trend for pembrolizumab to look better, but look at what has happened to the statistics here. The hazard ratio of 0.63, meaning a 37% reduction in events in any interval, comes down to a 19% difference, and the p-value from being highly significant goes to being non-significant. So if we come back to this trial that I've taken from Bishal's paper, this study is clearly subject to informative censoring, and that brings the result into a little bit of question, because as we've seen, if you correct for that, if you assume the patient's going off or because they couldn't tolerate the drug or they found it too toxic or whatever, then the trial gives a trend, but not a significant result as it did before. A forest plot is a plot that looks at subgroups. There was a forest plot shown in the paper, and it looked at age, sex or gender, performance status, where they were treated geographically, where this PDL1 score, and the type of nephrectomy and so on. And usually you do a test of heterogeneity. There wasn't any, but these are probably distributed around a constant effect. So the subgroup analysis isn't a problem. But it is important to recognize that an improvement in disease-free survival doesn't necessarily lead to an improvement in overall survival. Now, that may seem strange to you because you think, well, if they cut down on recurrence, people die because eventually of metastatic disease, so surely that leads to a difference in survival. Well, yes and no. So this is an old paper from Raymonding and colleagues at Princess Margaret, and he looked at the relationship between 2-year disease-free survival and 5-year overall survival in adjuvant trials for breast cancer. Different disease, but just to show the principle. And what you see here is, yes, there is a relationship, but it's not a 45-degree angle relationship. And if you actually look at these points, you could almost as easily put a straight line with no difference in survival through those data. And why is that? Because applying treatment at relapse might actually maintain equal survival. So you don't treat adjuvant, and then the patient relapses, you treat with the drug later, and you prolong survival. And so you can actually regain the difference in survival, even though the patients relapsed a bit earlier. And that can then lead you to say, well, why should we give everybody adjuvant treatment? Rather, we should just treat those who relapse and avoid the toxicity and cost of treating all patients at risk. Not something the companies will want you to do, but something that nonetheless is very reasonable. So this was their survival curve so far. And as you can see, there's no difference in survival out to about 20 months. There appears to be a slight difference appearing here, but it's not really meaningful because the number of patients who have died and the number of patients who have been followed for that length of time is rather small. So at the moment, we don't know anything about overall survival differences in this trial. But survival, as we just commented, is dependent on what you do after the patient's relapse. Now, so far, at the time that the most recent report was written in the Lancet Oncology, there were 166 recurrent events in the placebo group. So 1/3 of the patients who were randomized at the time of analysis had recurred. And obviously, there will be further recurrences as more time passes. And of those patients in the placebo group who recurred, 59 of them received subsequent immunotherapy. That's only 36% of those who recurred received subsequent immunotherapy. So 64% of the control patients who had disease recurrence didn't receive immunotherapy at failure, despite the fact that it's known to improve survival. So here is a big, big problem with this trial, that yes, there's a difference in the rate of relapse, but you didn't try to maintain survival in most of the patients by giving them a treatment that is known to work. Now, why would that occur? Well, a lot of these trials are accruing patients from different geographic regions. And of course, on the trial, pembrolizumab is provided by the company free of charge. But once the patients go off study, then either the patients or their insurance or their government plan will have to pay for that immunotherapy. And immunotherapy is so expensive that in most low and middle income countries, it's not affordable. So simply these patients, probably many of them in those situations, and some even in European countries, they just didn't have access to immunotherapy. And what's the evidence that improves survival? Well, here's a couple of trials. This is a trial of nivolumab for advanced renal cancer, looking at the old control, nivolumab, and these are overall survival. So clearly, nivolumab improves survival compared with everolimus for advanced kidney cancer. And here's a trial of first-line treatment where pembrolizumab plus a tyrosine kinase inhibitor is compared with the standard sunitinib, another tyrosine kinase inhibitor, a clear difference in patient survival. So the failure to give immunotherapy at relapse is a huge problem with this trial that doesn't seem to have occurred to the registration agencies. So coming back to this diagram, there is a very major problem that the patients who relapsed had substandard treatment. Then about external validity. Are the results of this trial consistent with those of other trials? Now, at the time of the publication, there were no reports identified for results from phase 3 clinical trials investigating other types of immunotherapy for patients with localized renal cell cancer after surgery. And they concluded that there was an unmet clinical need. And that was fair enough at the time that this paper was written. And as they stated, to their knowledge, this trial was the first randomized trial to report the results of a checkpoint inhibitor. But 3 additional trials of an adjuvant checkpoint inhibitor were reported at the ESMO meeting in September 2022. All of them were negative. This one has been published in The Lancet. This is even looking at disease-free survival, but in this trial, looking at atezolizumab, a PD-L1 inhibitor, there was no informative censoring. The dropout rates were not different. And as you can see, there is no difference in disease-free survival. And here are 2 others. They've only been reported so far in abstract form, but they both looked at different ways of giving nivolumab versus placebo, and both of them were negative. The first one hazard ratio 0.92, p-value of 0.5, and the second trial was stopped early by its data monitoring committee because early on the results were such that they were not going to see a difference. The relapse rate was almost identical. So in fact, we have 4 trials now of adjuvant immunotherapy, and only one of them, the pembrolizumab trial, has actually shown an apparently positive result, but with an endpoint that is not the final endpoint, that is overall survival. So the concluding sentence in the abstract of the recent analysis in Lancet Oncology states, updated results from this trial, Keynote 564, support the use of adjuvant pembrolizumab monotherapy as a standard of care for participants with renal cell carcinoma with an increased risk of recurrence after nephrectomy. So my question to you for discussion is, do you agree?